All right. So today we have really chapter 4 medication administration, one I really wanted to go over because this is going to be something that you're going to be dealing with day in and day out in the operating room. Your mini session, chapter 2, medication development, regulation, and resources, is up on Moodle. So make sure you go over there and check it out. Okay. We have Kahoot, and then we're going to wrap it up. You'll also know as we start to get more into the module, our live sessions aren't going to be as long as in the beginning where we're like right at an hour. So I do want to thank you guys for just sticking it with me on the first 2 weeks. So let's get into it. So it's all about medication administration. With every chapter, we have learning objectives, things that we have to cover. So we're going to look at abbreviations. We're going to talk about our role. We're going to talk about the 5 rights. We're going to discuss steps of medication identification used in the actual operating room and explain aseptic techniques for delivering medication to the sterile field because there are certain ways that it has to be done. We then have to look at labeling drugs. This is extremely important, and I'm going to share a story with you as to why once we get to that section. There's proper handling of medication, and then there's going to be different supplies that we'll use. We will then look at precautions for sharp safety because I don't care how cautious you are, there's still going to be that risk that you could potentially get stuck, unfortunately. It's kind of like the nature of the beast, I would say. All right, so here we go. Now, medication handling varies, ironically, by state to state and even facility to facility in the same state. Each member of the team plays a specific role in that particular process. Now, there are what's called limits of legal authority for the surgical tech. So, when we're performing different roles, we look at the text. We look to see if it's a controlled substance. And then from there, it's going to be again by each state through different statutes, case law, regulatory law, attorney general's opinions, and of course, the medical licensing boards. Now, our circulators, they are our team. They are like we're going to be Batman. They are our Robin because we're Batman. Okay. With that, medication administration from the sterile field, it's a team effort, not just one person. Like, we can't go and give ourselves medication per the book. And you'll get what I'm saying once you get into clinicals. Per the book, we're not grabbing our own medications and administering them. Okay. Now, we may serve as circulators or first scrub, so keep that in mind. We have 3 main duties regarding medication administration from the actual sterile field. Okay. This is where I'm like, we trust, but we verify. We are going to accept medications from the circulator. We're going to label them immediately, and then we pass them to the surgeon. If any medication is not clearly identified, we're going to throw it away. When in doubt, throw it out. Okay. We accurately identify and immediately label all drugs on the sterile field. This is extremely important. So, here's a question that I want you to think about. I want you to think about why it's done when, or what is done, I should say, when medications are not clearly identified. I mentioned it already like 2 seconds. When something's not identified correctly, what are you going to do?
Throw it away.
That's right. When in doubt, throw it out. Even if you are relieving another tech, oftentimes you may be a relief tech. So you may have 3 different techs that you're going to relieve. And I don't care if they say, no, no, you're good. That's lidocaine or that's heparin or that's saline. If it's not labeled, I'm going to throw it out and be like, okay, cool. Can I get another one up? Can you, not that they may be comfortable with that, right? But you're coming in to scrub for them and vice versa. Like if you're scrubbed in and someone's coming to relieve you, just having everything nice labeled helps out a lot. So what you see in the screen, we get what's called a sterile pen or marking pen, and we get sterile labels. Sometimes they're pre-labeled, and I think I have some to show you guys in 300, but we have pre-labeled where it already have the name, and all you have to do is write the amount and the expiration date. But if you don't, you also have the blank ones where you can write saline, okay, or lidocaine with epinephrine, morphine. And normally how we do it is, I think I have my little nasal spray again, is I'm the circulator and Carmen is my surgical tech. So she tells me that she's ready for her medications. So I'm going to come over to her and I'm going to show her the medication. And I'm going to say, moisturizing sinus relief. Okay. And then she's repeating it as she's writing. She's looking, and then she's waiting for me to tell her that expiration date of 07/08/2026. And then she's writing that 07/08/2026. Now, when she gives it to the surgeon, she's repeating everything except for the expiration date. So she's repeating, hey, doc, I've got your moisturizing sinus relief. Here you go. Okay. But it's almost everything's kind of simultaneously. Like she's looking, she's reading, she's writing. She's looking, she's reading, she's writing. Okay. And this is why we're always like, trust but verify. Now, box 4.2 gives you the 5 rights of medication administration. For medication errors to be avoided, we look at the 5 rights. We see when things have been established. That means we as a team have to work together. So you have your right drug. Well, we're in the operating room. So we have already checked the surgeon's preference card. We verified with our surgeon, and me and my circulator, Susanna, are working together. We've got this, right? So now we know that we've got the right drug, and we keep the drug vial in the room. That way we can always go back, especially because we do change people. Sometimes I'll get relieved before my nurse. Sometimes my nurse will get relieved before me, or sometimes we'll leave at the same time and then we come back. Okay. So we keep every suture pack, every vial, anything that is going to be administered to that patient in the room. Okay. Then we confirm the right dose. Nothing that we have to do by ourselves. A lot of pharmacies will send things up, so it's already pre-mixed per patient's name, and so you're just verifying. But you still want to make sure you have the right dose, the right route, and by goodness, definitely the right patient. And then when it comes to the right time, you're just actually giving the drug at the correct time. For us, that's going to be usually as soon as our case starts. Once the surgeon has gotten their light handles, their marking pen, their ray tacks, their cords where they want to go, we're giving them the local, which is the anesthetic, local anesthetic, right then. So for us, it's kind of like you're moving, here you go. Okay. Again, teamwork is so important. But I do want you to be cautious because there are similar sounding drugs. Pitocin versus pitressin, two different. Epinephrine versus ephedrine, two different. So you're always confirming if the patient has any allergies as well with the circulator, because even though they may have a standard drug that they give, if that patient has an allergy, then of course we let the doctor know and then they'll tell us, okay, give them this alternative. A lot of times they'll tell us before. Okay. So again, right dose. This is so important. The one thing I want you to know is that a lot of our medications we give are clear. No smell, they're just clear. Looking at that slide, you have 2 different strengths of heparin. One is used for one used for another. Okay. If you've got Marcaine, which is a anesthetic, You have your heparin. We usually use one for flush, one to keep a line open. So you have two heparins, a lidocaine, and saline. They're all in 10 cc syringes, and they're all in on your field. Especially if you're going to relieve someone and you see that, you're going to be like, wait a minute, what is what? Because you do not want to give a doctor, let's say, heparin when they just wanted a saline flush to like flush out, or vice versa. Now, that's why I brought this up. And you see 100 units versus 10 units, big difference. So when we are talking about the right dose, we are really looking at the correct amount and strength of medication, like that 30 cc's at 1%, 2%, or even 0.5% concentration. So to avoid all the confusion, there's written protocols that have to be posted, especially when mixing medications. But again, your circulator is going to usually be the one that's mixing it and handing it to you, or pharmacy is going to satellite it to you so you don't even have to worry about it. But regardless, you still have to label. Labeling each medication carefully is so important. And I'm going to tell you why. About 10 years ago, a little bit longer, 2009. Okay, a little bit longer than 10 years ago. So, about 10 years ago, we had a student in clinicals, and I get a call that said, this student is being pulled. And I'm like, okay, they're doing their final scrub. They're getting ready to really be done, have to just take their CST exam. And I'm like, what happened? Well, the preceptor and the doctor caught the patient or the student before they handed them the wrong medication, and the medication dosage would have, I always say unalive because I have a little one, um, you know, killed the patient. So in that instant, they had to be pulled from the case. Um, and they ultimately had other issues that were going on. And so they were pulled from the school. But at the end of the day, we always talk about being the patient's advocate, right? Well, something like that could have potentially been disastrous. Luckily, it was caught before, but we take it really serious because we've got patients' lives, in our hands. Again, with the right route, well, we're going to be in the operating room. So, for the most part, the medications are given intravenously, so that'll be anesthesia. Or if we're going to do it on the field, we're giving it straight to our surgeons. So, that's not going to be something that we're like, we got to make sure it's the right route. Well, we're in the operating room. Okay. But the things that you do look at is what I just mentioned. Okay. When you have different strengths, epinephrine for topical use is 1 to 1,000, while for injection, it's 1 to 100,000. These little things make a big difference. Remember, both solutions are clear. And that's why I bring that up. The surgeon's preference card is going to be your holy grail. I promise you. Um, and you always specify the route, even if it's on the card and we know what they want. We still going to check. Hey, doc, I know that this patient, blah, blah, blah. Is this what you still need? And they're going to
Oh,
tell you, yay or nay. And then you always read medication labels to help ensure that we're doing it the correct way.
sorry, Chip. Sorry.
No, you're good. It's also super important to know the route and purpose for different epinephrine strengths. Just like I mentioned with that heparin, a mix up can be life threatening. And this isn't to scare you, it's just to kind of let you know, hey, we've got a big responsibility. We have to closely observe the delivery of medications once it comes to our sterile field. You are going to be so super hyper vigilant when it comes to your field. You're going to be kind of multitasking as you're scrubbing. You're going to be looking, making sure no students are touching, coming too close, kind of like the clip I showed you guys at the beginning of class. You're not going to allow someone like that all up in your field. Trust me. Okay. We get the drug route, and we talk about why it's important because an error, a fatal error, could occur. So, what you see in front of you is the timeout. We're going to get into more detail with this in 300, but I want you to see. Now, they may look different facility to facility, but every facility performs a patient's timeout. Does anyone have an idea of what the timeout is about? And there's no wrong answers because we're all learning here.
To verify the correct patient procedure, side, allergies.
Yes, that is correct. Um, like a break to double check everything's all right, a rounding. So you guys are all on the right track. It starts before the patient actually gets to us, believe it or not, where different things are being checked. It's a checklist, right? Um, by the time we get here, and I really am going to emphasize this in 300, but when it comes to the right patient, everyone comes together. Anyone in the operating room can say, I'm ready for a timeout. Once that's done, it's like silence on deck, like a movie theater, like everyone's just stopping. And then we hone in. And then that's where we check the patient. We check allergies. We talk to each other. If it's a team that you don't know, you introduce yourself. Hi, I'm the surgeon. Hi, I'm blah, blah, blah. Okay. We are just making sure that all the information is correct. And so I love to kind of show this here as a preview so that once we get into, I think it's week 8, and we are going to actually act this out with a couple of you guys, you'll get the flow. And it's going to be something that you do. Okay. Every case. The one thing that's a little bit different facility is when you do it. If you look here, it says before skin incision. Now, before skin incision can be before prep, or it could be before the surgeon puts knife to skin. It depends on your facility. I've been at facilities where it's both, where we would be draped and then we would do the timeout. And then I had facilities, the children's hospital, we did not prep the patient until the timeout was done. So it just depends on the facility, the protocols, and the culture. Okay. Again, with the right time, we're in the operating room. Um, the surgeon is present. They're the ones really administering it. They're giving it to the patient to the sterile field, which is the incision site, when she wants the drug given. So we're kind of lucky in that aspect because the right time is whenever the doctor wants it. Okay. Now, keep in mind that medications given from the sterile table must be accurately recorded. And so a lot of times we're writing down. So if we give the surgeon 10 cc's of a medication and they give us a syringe back with 5, you're documenting 5 cc's given, because at the end of the case, your nurse is going to want to know how much lidocaine was given, how much irrigation was used, and we share that information with them. Okay. And then again, label, label, label. If it's not in black and white, it didn't happen. We have a sterile marking pen that is placed like I showed you again. And I like this one because you also have the start of the case items that we'll get to in 300, but you have your marking pen, your label. She has a Ray Tac, her Bovie, light handles. These are going to be the first things that go up even before the marking pen. So it's almost like you're handing stuff off to them, kind of keeping them busy so that you can bring your mail stand up, you can get your back table up, and then you can put your cords and stuff where you need them so that the surgeon is ready. Does that make sense? Okay. All right, good. Now, we do follow clear, organized process, and that's what box 4.3 is all about. If you go back to trust and verify, circulator is going to read the label to you. They're going to read it out loud. So don't let them just say, here it is. You want to hear it. Hey, I've got moisturizing sinus relief mist for you. Expiration date is 07/08/2026. And let's say I'm going to give you 5 cc's. Okay. So you're saying all that. They're showing it to you, trusting but verifying. Then you state the medication back to them. So then now they're making sure that you heard them, you accept the medication, and then you're labeling. And like I said, you can accept and label at the same time. In the lab, they're going to show you exactly how the book wants you to do it. I say that because you're going to see different things in clinicals, but I want you to always refer back to the book. Okay. Once it comes to like your CST. Now, there are a lot of different medications that you can receive on your field. 4.7 is just some samples of medications, including vials and ampules. You, as the scrubbed person, you're not touching this per the book. Okay. You're not touching this at all, right? We have aseptic technique. It has to be followed, especially when delivering and receiving these medications. Medications are going to come in a lot of different types of containers. So how it's handled is really important. Medication should only be accepted onto the sterile field after you've done what? And you can type it in. You're not going to receive medications verified. That is correct. Trust but verify. Trust but verify. I do not want to turn around and see some liquid on my field and someone saying, oh, it's such and such. No, no, no. I need this off and I need something new. And you can always, smooth it out so it's not like, get this off my field. But in your mind, you could be like, no, they didn't. And then in the real world, you'd be like, yes, I'm going to need a new whatever this is. Okay. Because at the end of the day, it's all about the patient. All right. So this is one method of receiving medications. You are the one with the gloves and your circulator has the vial. Now, in this instance, before they've turned it over for you, they've shown you. You verified it. You can even write out your label because then you can place your label on. The biggest thing is the needle that you puncture that medication with is not the needle that goes into the patient. So you're going to have two needles. Okay. You're going to have a larger bore and a smaller one. So you'll probably have an 18 and a 16 or 18 and a 12. Okay. You're going to draw up the medication with your larger bore needle. And then you're going to do the one scoop method to recap it. This is the one time you can recap because you're going to need to remove that needle, put on the needle for injecting onto your syringe. Okay. But notice where the circulator's hands are. Now, once you pull this needle back, as long as nothing is contaminated, you're good to go. Okay. And then you're able to label. Does that make sense? Because you guys will be practicing this next module. Does that make sense? Okay. Let's say you're super busy and you really just don't have time to pull away, grab a syringe, switch the needles, because 9 out of 10, you're probably not going to have a needle on it yet. Put a needle on and get it. There are instances where the circulator can draw the medication up for you. However, you're still going to verify it. Okay. What would happen is the circulator is going to show you the vial. They're going to have the syringe in front of you. They're going to say, this is what it is. You're looking, they're drawing it up. And then once they're pouring, they're going to say, can I pour this on your field? This is all per the book. Okay. Do I have permission to place it on your field? You'll say yes, or give me a second because you want to make sure where it's going. And then you kind of do the same thing. Exactly. Communication. That's what it really all boils down to. The key is unsterile hands must never touch the syringe. So even though in the operating room, they all wear gloves. So you don't necessarily have to worry about, they should all wear gloves. I had to stop myself because I remember I had some circulators, but they should always have on gloves. But again, their fingers are not anywhere near any type of plunger or anything like that. Okay. They're literally just drawing it up and then going to pour it into your medicine medicine cup. There is still another way that you can get medications onto your field, and that's with a decanter. And that's what this is. Okay. So, of course, this part is sterile. The whole thing is sterile. They'll pull off the cap. Same thing with everything else. They're delivering the medication from sometimes a IV bag, you see right here, or they can do it from a vial. A lot of times something needs to be reconstituted, meaning it's in a powder form, and they need to put a little saline in it, shake it up so that now it's in a more liquid form. And then they can do the same thing with the decanter. The good thing about the decanter, is that it has a little bit more space. So the distance is further where there's not as much of a chance of contamination. If you think about it, with, let's say, let me go back a couple slides with that, right? It's a little bit closer. So with the decanter, you do have more space, less chance of contamination between, the circulator and the scrub and your field. Okay. Any questions there? Yes, to make a solution. That's a good one too. Okay. So I really want to break this down, and this is why I put this one as like our dig deep, because you're going to be doing this. Sometimes you may have a sterile vial or you may not. So you have a vial on your back table, or let's say it's a medication that's in a vial. You're going to take a sponge, not a Ratex. Okay. We don't use Ratex or anything for any of that stuff. We don't use Ratex for prepping per the book. You don't use Ratex for anything that's not going to be on the going inside of a body. Okay. But sometimes we have to have vials. So with that, what the scrub does is we have the medication. In this instance, because this is on our field, now we show the circulator what we have. Same thing, we're still communicating, but instead of them kind of be like, this is what I'm giving you, this is where you go, this is what I have. This may be in a pack, or it may be in a package where you pop it up onto the field. Okay. Now, again, the scrub may pour the medication directly from a sterile vial into a sterile medicine cup with the sterile field. The biggest thing with ampules is that you just have to be careful, breaking the neck, kind of pushing it away, and you're gonna always want to wear gloves. Okay, especially if you're scrubbed in, you're gonna be gloved anyway. Again, I double glove. That's just my preference. And when you get to your facility, they may have you do certain protocols. Maybe they might say as a student, you have to double glove. There's some that may say you don't. Okay. I just always prefer to double glove. You guys know what I mean by double glove, right? Okay. Another thing is your under glove. So I am a 7. I'll wear a 7.5 under and a 7 on top. And I usually use that 7.5 orthos because they're a little bit tight, like they're thicker. So that's why I go a little bit ahead. And then I use my regular size on top. And those are just regular sterile gloves. All right. So here are some of the things I was telling you about. So now I'm bringing it together. Okay. You have your syringes. These are those pre-printed labels I was telling you about. This is usually the marking pen that you'll get, or sometimes you'll get the plain one that just has the purple cap. The most important rule, most drugs used in the sterile field are clear in color. Not most, almost like 80% of what we use on the field is clear. So if it's not clearly marked, it can get confusing. Okay. So here you have Marcaine with epinephrine, and this one's lidocaine. They're both clear medicines. So that's why it's clearly marked. And you'll also notice that they have corresponding. Now, this is kind of cool because the purple and the yellow and yellow, this is a little bit more fancy. Most of it is just going to be the clear. Okay. But if you are at a facility that has it where you can actually color coordinate it with the label, that is awesome. But lidocaine and then Marcaine with epi. So let's say the nurse was the one to squirt the medication in, they would squirt it right into your medicine cup. And then you would take the syringe and draw it up. So that's a couple different ways. With the decanter, same thing. If they were pouring the medicine, they would take the decanter cap off and then again pour it into your medicine cup. So you can kind of see with a decanter is a little bit more space in between, less likely to contaminate. And then at the end, this is what you would have. Sometimes, especially in ENT, when we're doing tympanomastoids or just mastoidectomies, these are just big ear cases, we will have epinephrine and we'll have our like little pledgelets kind of cut up, and then we'll have them in there and they'll go in the ears. And you've got to be careful that you don't mix it with like any other medication that's there. Again, I feel like I'm just reiterating, but it's so important. Label, 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 label. All containers, anything that's on your field. Printed labels are the best. Again, I like them, but not every facility is going to have them. Keep in mind that failing to label all medications on the sterile back table is just one of those things that we don't do. It's really a unacceptable practice and could be even considered negligence, right? So we don't want to ever compromise patient safety. We are that patient advocate, okay? Now, once we are in the operating room, okay, some additional handling may be necessary. Some medications may need to be diluted before use, not something that you would have to do. You wouldn't have to reconstitute or dilute anything. Like I said, it may come up from pharmacy, which is some of the practices that the newer, like the hospitals are trying to do now. And if it does not, the nurse and you are verifying, and the nurse is really doing it, and you're just kind of verifying, making sure. Okay. All containers again must be labeled, and the administration container must be labeled with complete information, especially if it's like a 50-50 mix. So you're writing all that down on that little label. We get into the type of syringes. Now, in 300, we're going to be breaking down syringes, we're going to be breaking down needles, we're going to be breaking down sutures. So again, this is me kind of like here, we're kind of like introducing it to you. So you have different syringes. So A is a 10 millimeter finger control lure lock, just means that it locks into place. So that right here is where it can lock into place. B is just the same thing without the lure lock. So technically, if you were to take this off, you can lock the syringe on. Okay. So you have this one with the finger, but the syringe and the needle will twist on, almost like a screw. If you think about it that way, if you look at it, it's almost like the screw. Okay. And so to take them off, because when you recap, pull down the cap, you're gonna just screw off the needle. And then we have our TB, tuberculosis, or 1cc. Okay. I have seen questions about that tuberculosis or tuberculin syringe. So make sure you kind of read up on it. This is the 1cc. So if you see a question hypothetically where the surgeon needs a 1cc amount of medication, what type of syringe would you use? Keep in mind, remember how many cc's are in a TB syringe. Because you're not going to see, you may see 5 millimeter, you may see 10, you may see a lure lock. Remember how much? And then you may see a TB syringe or tuberculin syringe. They're not going to let you know that a tuberculin syringe is only 1cc. So you kind of have to remember, okay, I remember that picture. 1cc. You guys got it? And again, you might not get that concept, but you might. Now, again, we have different syringe types. You have your regular, again, that lure lock right there. Think of it like a screw. This is the one you're going to use a lot. We have eccentric, your catheter. A lot of times, if we are irrigating some stuff, you may have this type, or if you're doing urology, you may have this type. And then even the Toomey. Okay. The Toomey is just a larger type of syringe. 30cc or 30 ml syringes are most frequently used to irrigate saline irrigation and contrast media into the common bile duct, usually in gallbladder surgeries, also known as cholecystectomies. Okay. And then you have what's called a tube X with a rubber cap. So you can actually put the syringe in here and it'll be a little bit easier to go through. And sometimes you may see those. So this right here will be placed in the tube X because you'll notice that the syringe has medication in it already. So we place this into the tube X and you kind of use it just like a regular syringe. Basic parts of a needle. Now, I am a visual person and some of these colors are off, just so you know, because we normally use an 18 gauge, which is usually pink, not green. But for whatever reason, it's green here. So we normally use an 18 gauge needle. And a lot of times 27 for injection. Remember, the larger the number or gauge, the smaller the needle. And it's the same for sutures as well. Okay. I'm working on breaking down that suture because we have a huge suture presentation in week 10. So I'm working on that to get that like so that it really breaks it down for you guys. But just remember, the smaller the gauge, the bigger the needle. The larger the gauge, the smaller the needle. Needles vary in diameter and in lengths. Most hypodermic needles used in surgery are disposable. We are not reusing these needles. The three needle sizes most frequently used is your 18 gauge, that's actually pink, sometimes a 22 gauge, that's actually gray. And I know these are off kilter, and 25 and 27. Um, in the cases that I'm usually in, I'm usually using an 18 or a 27. So, but surgeon may prefer a certain needle and that's what you would give them. Now, the question you guys should be asking, what needle would I be using to drop my medication? If you're looking at this chart, which one would you normally use? Keep in mind, the larger the gauge, the smaller the needle. The smaller the gauge, the larger the needle. You could use a 14. 14 is a great size. Most likely, it'll probably be a 16 or an 18. So just keep that in mind. Yeah, 16 or 18. But then again, it's going to be per facility, and your preceptor will definitely kind of guide you as to which one you're going to use. But you always go larger. And with that same thought, you've got two needles on your back table. You've got a 27 and you've got an 18. Those are the only ones you have. And so then you can kind of gauge, like if you have a 16 and a 27, then you know that that 27 is going to be used for injection and that 18 or 16 or 14 is going to be used to draw up the medication. Now, the other thing that we have to be careful is our sharp safety. During this whole thing, we don't just have our needles just laying on our mail stand, chilling on the sterile field, having lunch on the back table. Okay. We have a designated area for our sharps. So what you see in the right corner is what we call our mag pad. And what you'll also notice is this individual is recapping. So most likely they had the cap on the spongy part. This spongy part helps us keep account of our needles. They are numbered. Usually in neuro, I tend to do two a number because there's a lot of needles in neuro. But if you have a smaller case, you just have one needle per little section, okay? And they are as small as single, double, or even triple. But I want us to look at recapping a needle because, like I mentioned, it is one of the things that we may have to do because we're not going to inject our patient with the same needle we've pulled our drugs from. So let's take a look.
Hey everyone, it's Sarah, registered nurse, RN.com, and in this video I want to demonstrate how to recap a needle using the one-hand scoop technique. Now you want to avoid recapping needles due to the high risk of needle stick injuries. However, sometimes as a nurse you have to recap a needle. And to do this safely, you want to use a technique that decreases the risk of a needle stick. When recapping a needle, you want to avoid using this technique as it carries a much greater risk for a needle stick injury. Therefore, it is recommended that when you do have to recap a needle, that you use the one-hand scoop technique. So I have a situation where I need to recap this needle because I have used this needle to withdraw medication from a vial, and I need to remove this needle and apply a new one so I can administer it to the patient. So I have kept the original cap and packaging to help assist me do this. So what I'm going to do is I'm going to use just one hand, hence why we call it the one hand scoop technique. I'm going to keep my non-dominant hand by my side, so I'm only going to have my dominant hand holding the barrel of the syringe. And then carefully I'm going to place the needle inside of the cap until I can no longer get it inside the cap. Then I'm going to lift up like this and then take that one hand that I wasn't using and just snap the cap on. Alternatively, when using the one-hand scoop technique, some protocols require that you use a hard surface to snap the cap into place without using the other hand. Then I'm going to remove and dispose of the needle per my facility's protocol. Okay, so that wraps up this demonstration on how to recap a needle using the one-hand scoop technique. And if you'd like to watch some other nursing skill videos, you can access the link in the YouTube description below.
All right, I figured that would be easier because I'm like trying to show you virtually. So I was like, I need to find a video where they're actually doing it. Keep in mind, we're doing this at our sterile field, or we're doing it on our back table or our Mayo stand, not our sterile field, because the sterile field is the surgical incision, okay, or the surgical site. So a lot of times we'll keep, now this part right here is magnetic. And that is also good because if you can look closely, there a lot of times we'll have our knife blades, especially if we've used them, we'll remove them from our knife handle, and I'm going to show you how to do that later as well in 300. And then we place them in this magnetic area. This is really important when you have those little small like ophthalmology sutures. A lot of times we'll actually take our marking pen and kind of dot so that the little silver is sticking out. Okay. Any questions on that? Okay, perfect.
Hey everyone, it's Sarah.
Like I mentioned, we're getting into the meat and potatoes of our lessons. So our live sessions are going to be more focused, more kind of related. We are going to be talking about a lot of medications in this module, but you'll notice how it relates to why it's important for us. There are certain things that could happen in the operating room, or certain medications. For example, we're going to talk about malignant hypothermia. And whenever you talk to anyone in healthcare and you say malignant hypothermia and you're thinking about the drugs, the first thing we're thinking, where's the dantrolene? But we're going to talk about that. We're going to be talking about Narcan, and yes, we do use cocaine in the not we, but we do administer it in the operating room for certain patients. I had it on my back table when I was doing an airway case. So there are certain things that we're going to talk about, and you're probably gonna be like, we use that. And I'm gonna hopefully be able to kind of show, yeah, we do. And these are the certain cases that we use them in. So what questions do you have for me before we get into our little Kahoot that I already have up? All right. So let me share the game with everyone. For those of you who are watching, I am going to be placing the Kahoot in the live archive section. I think that's the best. And then moving forward, so that when I put a whole bunch of stuff on announcements, I know it can be overwhelming. Now you'll have a spot. So anything that we go over in the archive, let's say there's a video we don't get to or a Kahoot we don't get to, I'm just going to place it in that archive section so that you can always go back. You don't have to kind of go through the announcements to search for it. It'll just be in that week we actually covered it. Okay. I'm going to go ahead and start. Now, this does cover both chapters 2 from the mini session and chapter 4. Okay. And again, for those of you who are watching, the link is going to be in the archive. And I think there's only 8 questions. Yeah, there's only 8 questions. Okay, I know some are working, but there are 20 of us in here. I see 8. I know there's at least 3 that are working, and I know one person's driving. So awesome. So I know there's 2 persons working, or 3 people. Thank you. Thank you. Okay, awesome. You can type your answers in as well. Okay. I'll wait a couple more seconds for maybe a few more if you can. If you can't, again, you can type your answer into the chat and you'll be golden. And this is the last thing we have to do. All right, everyone else, you can go ahead and type it in the chat, okay? Here we go. Oh, there's 10. World Health Organization. So again, this is from chapter 2. Yes, issues, recommendations, and guidelines. And so what you'll notice is that I have shrunk it to 10 because I want to work on muscle memory. And that's just like recall. This is going to help you with your examinations, with your knowledge checks, so that you don't second guess yourself as much, which is one of the things that I am working on too. Like I always second guess myself. Yes, state laws vary for drug dispensing administration and administration. Returning it to pharmacy. So when we have an outdated multi-use, a lot of times, and I love this because we usually get discarding, because when in doubt, we throw it out. Okay. But if it's like a multi-use vial, it'll come up in pharmacy, and I'm gonna have to rephrase that question. But if you do see it, it will be rephrased. Well, you guys will know it, but moving forward, when it's a multi-use from pharmacy, that's the key word, from pharmacy, we send it back to pharmacy. Okay. So if you see that, it won't be changed before, you know, this week. But if you see it with the word pharmacy in, then you'll have a cue that I was able to get it changed. Yep, it's never capitalized on the label. So what I did is I tried to show the picture, and I know it's kind of deceiving, but that way you'll, in your mind, you'll be like, amoxicillin was not the generic name. But then if you look back, then the generic name was actually lowercase. And you can look on your medications. If you go get a generic of a medication, you'll notice that or any type of medication like the acetaminophen or whatever, the generic name is going to be lowercase. Okay. And you may see that one again. Right. That is correct. Because remember, the larger the gauge, the smaller the needle. The smaller the gauge, the larger the needle. Five millimeter. So you don't want to use a 1 millimeter, and hear me out. When you're doing an embolectomy, I want you to think about we're trying to remove an embolus or blood clot or something like that. So if we use that 1 cc TB syringe, we'd have to fill it up a couple times. But if we use a 5 cc syringe or 5 ml syringe, we can actually draw up exactly 3 cc's, so that now we do it in one spot. Think of emergency cases, okay? We try to do things where we're not having to go back and forth. Does that make sense why it's 5 versus the 1? Perfect. Yes, the FDA. 2 more questions. Keyword, accept. So think about which ones we definitely want to know. Which ones like it'd be cool to know. Exactly. Physician, it's nice to know, but everything else is what we really want to know. It is a class 2. So make sure you guys go back because I have seen a couple questions on even the midterm about the different classes and concepts of those from C1, C2, which ones for pregnant females, etc. So make sure you have a good grasp on those classes, okay, or the schedules of medications. And number 10. Keyword, international. That is correct. So keyword international, looking at the world. Good job. Good job. And good job to everybody that was able to answer as well. All right. My thing just, there we go. I'm like, my thing just broke down. All right. So what you see is what we do, right? We look at our medications, we check with our circulator, we trust, we verify. If it's not verified, then we're not accepting it, right? What's another thing that we do that you see on the screen? What is one thing we have to do once those medications are being shown to us? Go ahead.
Label.
That is correct. We label, we verify. And then, of course, we're going to talk about how we pass the medications to our surgeons in ST300. And there's a couple ways, believe it or not, that we do it. For those of you that are watching the playback, what is the role that we do in medication administration when serving as the actual scrub tech? I also want you to give me examples of applications of the 5 rights of medication administration that are in surgery. And how would you label your drugs on your sterile table? You guys, week 2 is behind us and we're moving quite fast. Keep in mind that in 3 short weeks is none other than our midterm. It's going to be here before we know it. And then we're going to be getting ready for finals and summer and the whole 9 yards. With that, I do want you guys to have a wonderful, wonderful, wonderful rest of your evening. Have a wonderful rest of your week. Be safe this weekend. And I look forward to seeing everyone who can attend next week's live session. Good night, everybody.
Okay.